Good morning, everyone. And first of all, I would like to thank the National Cancer Control Program for inviting me to deliver this lecture. I know it's half an hour to me, and I'm just going to give you an overview of principles of symptom management in palliative care. Symptom control is a major component in palliative care, palliative medicine, and people with life-limiting illness may experience a range of symptoms depending on their underlying pathology, comorbidities, psychological, social, and environmental factors. So our aim is preventing, minimizing, and treating these symptoms when we look after these patients. And even in the palliative care definition, it is very well written. Social, spiritual, psychological, physical symptom has to be controlled. So I'm concentrating only on physical symptoms here. So the common physical symptoms are fatigue, pain, breathlessness, anorexia, constipation, emotional distress. And it is very well studied and find out that not only the cancer patients, even in non-cancer patients, they have a whole load of symptoms. Even the pain, dyspnea, constipation, anorexia, nausea, those are mainly comes as more prominent symptoms in these patients. So there are a few things we need to keep in our mind when we assess and when we evaluate these symptoms. A person's symptoms don't always follow a predictable pattern. For example, if we think that this patient has this amount of secondary deposits and the pain should be this much, that's wrong. It's not always like you predicted. And the other thing is symptoms are subjective, experienced differently by a different person. Same problem, same intensity in the CT or X-ray or ultrasound scan, the patients experience these symptoms differently. And because symptoms are multidimensional, it have multiple contributing factors. So when we assess symptoms for the management, we have to do a comprehensive assessment. We need to assess, we need to identify the focus of the problem to decide on intervention. And we need to implement our intervention, and we need to evaluate whether it has worked, whether it has the outcome of whatever the intervention. So in comprehensive assessment, for example, if we say nausea, because there would be a pain lecture separately, if we say nausea, depending on the characteristics, whether there is abdominal bloating, whether there is regurgitation, whether the smell of food get really nauseated. So characteristics, we can find out what is the pathophysiology behind this nausea. Even the pain, whether there is radiation, whether there is numbness, whether there is local tenderness. So likewise, depending on the characteristic, we can have some idea about pathophysiology. And depending, we need to find out what are the contributing factors, aggravating, revealing factors, as well as contributing factors. For example, if somebody has CA cancer, pelvic cancer, if the patient has urinary tract infection, it would further aggravate the pain. And at the same time, the patient's behavioral response. For example, small children, especially elderly, the behavioral response is sometimes completely different than the symptoms. The patient may be having nausea, but the behavioral response is just depression. The patient has pain, a small child, the behavioral response is crying or running here and there. And at the same time, patient has different meaning to the symptom. Someone say that this abdominal pain came because I took that medicine or took that whatever the candle or something. After that, it came. And this headache is because my mother said I had a fall when I was a child from bed. And somebody says this back pain because of the spinal given for LRT surgery. So likewise, the meaning of the symptom to the patient is we need to find out. So unless we comprehensively assess all these things, but by giving just a medication or pill, the symptom will not be relieved. So in symptom assessment, as I said, the contributing factors, the characteristic of symptoms, for example, pain, intensity, location, quality, temporal nature, frequency, we can find out we can download the pathophysiology behind that, meaning given to the patient. It has a major contribution of the patient's physical, psychological, social well-being, and the behavioral response. So it's very important to keep in back of our mind that the assessment of pain quality allows for us to diagnose the type of pain. So then we can decide the appropriate treatment plan. For example, depending on the patient's pain characteristics, we can assume that there's a neuropathic component to the pain. So then we can decide on appropriate treatment plan. And if the patient has nausea, just by smelling the food, we know that it has come from the central chemoreceptor trigger zone, central nausea. So we have to decide on management plan. So likewise, we need to assess the characteristics of the symptoms and assess and determine the appropriate plan of management. And there are four clinical key components in palliative symptom management. One is the treating the underlying pathology. For example, if patient comes with shortness of breath, if it is due to large pleural effusion, the treatment is draining of the pleural effusion. If the patient has pneumonia with some bronchospasm, the antibiotics and nebulization. If the headache is due to raised intracranial pressure, then the steroids. So likewise, the treatment should be based on the underlying pathology. The next thing is the change in sensation or perception of the symptoms. So why do we give opioids to patients who has breathlessness? Why do we give opioid in patients who have pain? We give opioid in patients who have pain because opioid has direct action on pain management. But we give opioid in patients who have breathlessness, small amount of morphine, because it will reduce the awareness of breathing. Breathlessness is you feel breathless. You have difficulty in breathing. So opioids will reduce the awareness of breathlessness, breathing, and then patient do not feel breathless. So that is how we change the sensation or perception. So heat may influence the perception of pain. The severe pain might blocked by the heat due to, so likewise, we change the perception of the symptoms by giving some medications. The next thing is always these symptoms have other contributing factors, emotional reactions. If you are breathless, it's really a fiery feeling that I'm going to die. I'm going to die, choke. So if we train them relaxation, and if we reduce their anxiety by anxiolytics, and then the breathlessness breathlessness will improve. So diminishing the emotional reactions. The next thing is optimization of function. So why we do all these things? Because our main aim is to relieve symptoms as well as to improve the quality of life. And so the optimization of function we can do by providing some equipments. So if the patient being given some assistance in reducing breathlessness, providing some equipment to reduce the work of breathing, then we are optimizing the quality of life, optimizing the function. So likewise, one is we need to treat the underlying pathology. The next thing is we sometimes use medications or some methods to change the sensation or perception of symptoms. And we need to think about other additional associated factors and the aggravating factors. So we need to diminish the emotional reactions, and we have to think about how am I going to optimize the function by controlling this pain or whatever the distressing symptom. So after doing impeccable assessment, as in the definition says, we have to integrate pharmacological as well as non-pharmacological methods. For example, if it is shortness of breath, pharmacological method depending on the cause, the bronchodilators, antibiotics, morphine, and non-pharmacological breathing exercises, relaxation techniques, right? So likewise, we need to integrate pharmacological as well as non-pharmacological methods. We always target the cause, as I said. The dyspnea is due to pleural effusion. We have to drain. If the nausea is due to constipation, we have to clear the bowel, right? We should target according to the cause as well as contributive factors. So if the pain got worse due to superadded infection, we give antibiotic and treat the infection to improve the pain. If the shortness of breath got worse due to pneumonia, we give antibiotics. So we need to target the cause as well as the contributive factors. So once we done that, now we have several methods of pharmacological as well as non-pharmacological. Are we going to implement all those things to this patient, to introduce all of this to the patient? No, we should tailor according to the patient's preferences, patient's beliefs. For example, one person might say, I really want zero pain. I can't tolerate pain at all. So we sometimes give medications, sometimes to zero pain, patient might be now a little bit drowsy. But sometimes one person might say, no, I can tolerate some pain, but I want to be very alert. I want to do a little bit of gardening at home. So whatever the medication or whatever the management, we should tailor according to the patient's beliefs, preferences, circumstances, as well as finances. So now these principles I'm going to try to apply some symptom management. So you can disturb me at any time, and vomiting is forceful expulsion of gastric contents through the mouth, right? So nausea and vomiting. So how are we going to assess? We need to review the history and recent investigation. We have to review medications, whether the medication has caused the nausea. And we have to do examinations, looking for underlying causes, and do some investigations to find out any underlying where the symptom came. So for example, we examined the patient and found out that there is some abdominal distension in this patient who has nausea and vomiting, and we do X-ray abdomen full of feces, right? So likewise, we have to do a comprehensive assessment, right? And whatever the symptom we are dealing with, we have to have rough idea of the mechanisms. For example, nausea and vomiting, we have to have rough idea of the mechanism of nausea, because the drugs that we use, depending on the cause and the mechanism, right? So if the patient has anxiety, it acts on the cerebral cortex, so we have to find a medication which acts somewhere there. So that is how we should have rough idea of the mechanism and the neurotransmitters, as well as the mechanism of drugs, right? So as I said, whatever the intervention that we have to do, we depend on the cause. So so then we have to find out what are the causes for nausea. The drugs can cause nausea. The common drugs we use in palliative care, chemotherapy and opioids. There are gastric causes, gastritis, ulcers, functional gastric stasis likewise. Constipation can be a cause, intestinal obstruction, biochemical causes like renal failure, infections, hypercalcemia, tumor toxins, raised intracranial pressure, not only cause headache, it can cause even nausea, vomiting, vestibular dysfunctions, and sometimes cough-induced. You might have seen some patients cough, and then they vomit. So as I said, when we have an idea of the neurotransmitters as well as the causes, we have to assess. We need to find out whether there are reversible causes, and we need to treat according to the pathophysiology, and we need to decide on antiemetic depending on the pathophysiology, right? So depending on the pathophysiology, we need to select antiemetic. For example, if the problem is in the stomach, small intestine, what are the agents that we can use? If it is due to labyrinthitis like vertigo, what are the agents like beta histine, stemetil you can use? And if it is due to the higher cortical problem, then we might have to think of giving metoclopramide, haloperidol, chemoreceptor triggers on. What are the things that we can do? Likewise, the drug treatment depending on our analysis. So we need to select a proper drug for the proper patient, right? So these are the common drugs that we use in Sri Lanka, and metoclopramide reduce the what are the side effects we need to, and at the same time the mechanism of action as well as the side effects. So users, ondansetron we commonly use in chemotherapy-induced nausea and vomiting, and sometimes we have seen even the patients come with gastroenteritis, people used to be ondansetron. But that is not actually very rational, but still, because it can cause constipation, sometimes it may be effective. But at the same time, patient end up with severe constipation at the end of the treatment of gastroenteritis, right? So if the patient has motion sickness, we have to give something like beta histine. So if the patient has nausea, vomiting due to migraine associated, then dopamine. So likewise, depending on the symptom, depending on the analysis, we have to decide what drugs. If the patient has vomiting, gas, and nausea with reflux, we have to think about giving metoclopramide domperidone. If the nausea is due to morphine, the drug of choice is haloperidol. So likewise, we have to have idea what we have to do. And then if the patient has severe intractable nausea, which is not responding to anything, we have to think about colonic fecal loading, hypercalcemia, upper gastrointestinal inflammation, bowel obstruction, race. For example, opioid-induced, we can use metoclopramide, haloperidol, cytotoxic chemotherapy-induced, ondansetron, renal failure, haloperidol, functional gastric stasis, metoclopramide, cisapride, which we don't have here, inoperable bowel obstruction, metoclopramide, octreotide. So likewise, we have to do a thorough assessment to decide on what medication are we going to give. If it is hypercalcemia, we have to give bisphosphonate rehydration. And if it is nausea is due to infections, we have to give antibiotic. Urinary tract infection and common infection, gastroenteritis can cause nausea. If the nausea is due to raised intracranial pressure, we have to give dexamethasone. If it is due to gastric irritation and ulcers, we have to give proton pump inhibitors. Constipation, rectal measures and laxatives. If it is the nausea is due to anxiety, we need to give an anxiolytics. So I think now you understood that the principles which we apply in assessment of symptom control. If I have time, you can disturb me at any time. I will tell you how we apply these basic principles to other symptom control as well. For example, breathlessness. When a patient is breathless, it's very important us to analyze the breathlessness. Breathlessness also has three parts: the breathing part, the work of breathing. You breathe in and out fast. So that is the breathing cycle that we always think about and look at. But there's a thinking part as well as functioning part. Thinking part, the patient has past bad memories of breathless experience, and patient has misconception and thoughts that patient is going to die. Patient is anxious, getting sometimes frustrated, angry. So there's a thinking component as well as a functioning component. Because of the breathlessness, patient has reduced activity, they are being socially isolated, and then they become deconditioned, cardiovascular decondition, muscular decondition. So there are three components in assessment of breathlessness. So depending on the dominance of the three components, we have to plan the management. If the work of breathing is the most important thing, difficult thing, then we have to train the breathing techniques. We have to give some handheld fan, airway clearance techniques. So likewise, we have to concentrate on work of breathing part. If the patient is not much difficulty in breathing as well, but the thinking part is more prominent, then we have to explain them and train them relaxation techniques, sometimes drugs like anxiolytics, mindfulness. So likewise, we have to think of. And if it is the functioning part, because of this shortness of breath, patient is now getting exhausted, then what decondition, then we have to think about pulmonary rehabilitation, limited pulmonary rehabilitation, some exercise and activity to improve the upper limb, lower limb muscles as well as the intercostal muscles, and to give some good nutrition supplements. So likewise, we have to assess 3 cycles, right? The therapeutic, otherwise, the other therapeutic options that we have is if the patient is hypoxic and if the patient feels better with oxygen, so we can give oxygen. We can give opioids to reduce the awareness of breathing and improve the breathlessness. Then the quality of life and mobility, everything would improve. If the patient is quite anxious, we have to give anxiolytics and relaxation techniques and other measures. And as I said before, we have to always think about the cause. From the beginning, as I said, if it is a pleural effusion, aspiration, or any shunt, pericardial, the breathlessness is due to pericardial effusion, pericardial census. If breathlessness is due to hypoxia, oxygen. If breathlessness is due to lymphangitis, we have to give high dose steroids. If it is due to endbronchial disease, sometimes steroid, laser therapy, the oncologists know everything. I'm just giving you the rough idea. Depending on the cause, we have to do some more additional, we have to make additional measures to improve the symptom. The final thing is constipation. So constipation is passage of small or hard feces infrequently or with difficulty and less often than the patient's normal bowel habits. So when we assess constipation, we need to assess the associated symptoms as well. Flatulence, bloating, abdominal pain, feeling of incomplete evacuation. Those are the things that bothers the patient, right? Rather than not passing just stools. And other complications, like because of the constipation, patient develop anorexia, nausea, vomiting, overflow diarrhea. Due to constipation, urinary dysfunctions, urinary retention, sometimes urinary tract infection. And in patients who are very unwell, patients with malignancies and elderly patients, they become confused purely because of constipation.
Excuse me, madam, you have only 5 more minutes.
All right, so we need to assess, right, the complications as well as the patient's symptoms, and we need to have an idea what are the causes to constipation. There are pharmacological agents, there are metabolic causes, and there are neurological problems, right, and structural abnormalities, and functional causes, diet, environment, and other factors. And then we have to do examination, abdominal stoma, rectal examination, some investigations, and then finally the digital rectal examination, and the other underlying things like hemorrhoids, ulcers, and we have to look at the feces, the Bristol stool chart, and then we have to decide on laxatives. Again, the laxatives, we should know what are the laxatives which predominantly soften the stools, what are the laxatives will stimulate the peristalsis, what are the rectal laxatives available, and what is the best choice for this particular patient, right? And the choices of laxatives, enema, rectal enemas, we have to. So the final is, the management is, first line, we have to give either stimulant or osmotic diuretic with or without a softener. And the second line is the sector. If it is not going to work, we have to think of giving rectal suppository and enema. The third line is sometimes we have to give manual evacuation. So I think, even though there are a lot of stuff I spoke to you, what I really want you to understand is that each and every symptoms we need to evaluate. We have to have a very good idea what is the cause and the mechanism, and we have to have a very good idea the treatment method, pharmacological as well as non-pharmacological methods, how it acts. And we need to choose the correct treatment method, pharmacological and non-pharmacological, to the patient. And we need to assess whether it's working, and we need to tailor according to the patient's requirement. Okay.